Welcome everyone to the 25-26 Endocrinology Grand Round series. So this is our first Grand Round for the academic year. And I would first start off by thanking the people who have worked to arrange this over the years. Those include, of course, Kelly, who does all the logistics and everything to get this done. To get the all the schedules and everything and contacting people. Wintergurst and his team for working with us and presenting the pediatric side of the endocrine grand rounds, and also Kerry Kling for the cellular and molecular endocrinology. So today I'm going to talk broadly about this topic of steroids and diabetes. This is a fairly common problem, although I must say there's also a problem that's not studied intensively. It's a difficult area to study because of the heterogeneity of the populations that are there. So we'll discuss some of the issues related to this particular topic. So I don't have any conflicts related to this particular topic. That is. Yeah, I probably have to. No, I'll have to exit the screen, I suppose.
Oh, good. Yeah, I have our spring plan. When you want it. Okay, to click on that. Oh. We're trying to, oh, yeah, now it's good. We're trying to remove
I'm trying to remove that
Oh.
thing here.
Either that or just. Here.
That's it.
Do something.
You do that, you guys can- No, zero. I mean, pretty sure.
Okay.
You just. Eventually, I agree. Everything on there.
That was weird that we're not sharing. Bear with us, guys. Okay, let's do this. It's there, but not here.
Yeah.
Stop sharing. And we're gonna share, and we're gonna do this. And we still have that. Yeah, it's that one.
Still there.
Yep. That's so weird. How do not available. So if I get rid of that,
Just do a slate up view
huh?
with no presenter view.
Let's see. Okay. Don't ask me what I did. Let's
Okay.
see. Okay. Is that all right?
Okay.
Gosh, that was weird. Don't ask me.
Okay. Sorry for the brief interruption. As usual, technical problems, especially starting off the year. So I'm just going to go over some of the brief history of glucocorticoids that are relevant to this particular topic, and review the effect of steroids on glucose metabolism, and discuss both problems with blood glucose and endogenous hypercortisolism and exogenous steroids. So steroids have a long history. In the 19th century was when the first discovery of glucocorticoids was made, when Thomas Edison identified a patient who was suffering from chronic fatigue, muscular degeneration, weight loss, and darkening of the skin. And he found that, you know, the adrenals were small, and later they were able to give um, that there was beneficial effects of giving an adrenal extract. So it was in 1908 that it was first established that something from the adrenal gland, or substances they call secreted, were involved in glucose metabolism, because in adrenal-ectomized dogs, these dogs developed hypoglycemia. So after that, a number of studies over the next few decades um, identified the critical role of adrenal cortex in metabolism and energy homeostasis. So those were characterized. And then they, in 1936, two groups, one Polish-born Swiss chemist, Reichstein, and American chemist, Calvin Kendall, they both identified an inactive form of the adrenal hormone cortisol known as cortisol. So really, it is interesting that the impetus for more research on this was actually World War II, when they found that there was this rumor, this was a conspiracy theory, because I think later they found that it was not true, that the German soldiers were getting, the pilots were getting these shots of adrenal cortex, these hormones that made them perform better at high altitudes. So there was a flurry of activity to try and identify and synthesize different active adrenal hormones. So that is what led to the you know, isolation and later synthesis of a variety of hormones. So in 1946, Kendall isolated 4 steroidal compounds from the adrenal extracts, which he named as A, B, E, and F. Compound E would later be known as cortisol and was synthesized that same year by Sarret. And the newly produced cortisone indeed improved the symptoms of Addison's disease. So that was the first use of adrenal, the purified adrenal extract, or the hormone itself. So later on, people identified that this particular hormone could be used in inflammatory disease, and the first thing was Hench used it for people suffering from rheumatoid arthritis. So Hench and Kendall were awarded Nobel Prize for Medicine and Physiology, along with Reichstein for their work in steroids in 1950. So eventually, the cortisol was discovered and later developed as a separate product as such. So since then, there has been a lot of advance in our understanding and use of corticosteroids. They were the first anti-inflammatory drugs, and even today they are probably the most widely used and most potent anti-inflammatory drugs that are there. So 7 decades later, they remain the cornerstone for many inflammatory diseases. So that's the background of the discovery and use of these steroids. So this kind of gives us a kind of a roadmap as to what was happening starting in 1945, where 49, when the first application for hydrocortisone or cortisone was published, and subsequently the identification that the receptor for steroids was a nuclear receptor, and the identification of glucocorticoid receptor. And then in the 70s, the concept of RNA synthesis by glucocorticoids, to how they act. Then the glucocorticoid response elements were identified in the 1980s. The glucocorticoid receptor itself was cloned in 1985. And then, there are more developments in further identifying these trans-repression identification of a variety of glucocorticoid actions, the knockout animals that were developed, to study the whole spectrum of action of these hormones. And then now coming to the current day, trying to use modifications of the protein or ways to modulate the action of the glucocorticoid receptors by synthesizing different kind of analogs of these uh, compounds to modulate whatever we want, so that we could have anti-inflammatory effect without metabolic effects or the other way around. So that has been the brief history of what we know about steroids as a whole. So you can also see that the publications on glucocorticoids, since and just related to this topic of glucocorticoids and diabetes, there has been a huge increase in the number of publications that have been there. And in recent years, there has been a lot of interest in understanding steroid-induced diabetes. And that is related to the huge number of prescriptions that are in the United States alone. There are about 10 million prescriptions written for steroids every year. So it's a large number of people who are receiving it. And of course, there is the endogenous hypercortisolism. So I will discuss both endogenous and exogenous steroids and their effects on glucose. And to start with, we'll just go through some of the basic actions of cortisol as to what it does in different tissues. So then there are these direct effects of steroids in different tissues, and there are indirect effects. So in the whole body, there are multiple ways by which steroids affect glucose metabolism and energy metabolism in general. So in the liver, it promotes gluconeogenesis and increases glycogen storage. In the skeletal muscle, it directly inhibits glucose uptake and oxidation, reduces glycogen storage, and increase protein degradation to provide amino acids as precursors for gluconeogenesis. So one of the main things that is there in the action of steroids is that as a stress hormone, when we look at the effect of steroids on glucose metabolism, it appears that its role is to make sure that there's enough energy provided to the brain, particularly in the form of glucose, under stress. So that's the reason why when there is stress and the steroids go up, they increase the breakdown of stored glucose and also synthesis of new glucose to supply it to the brain for normal function. So they also have effects on inhibiting glucose uptake and oxidation in the adipose tissue, increases lipolysis. And in the pancreas, it has an effect of inhibiting insulin secretion in beta cells, increases glucagon secretion in alpha cells, and also increases beta cell hyperplasia. So there are multiple effects that steroids have directly. So when you go in at the cellular level, you can see that these, the ones that are marked yellow are the enzymes that are directly modulated by steroids through its action on regulating the activity of these enzymes. So this is the classic pathway of gluconeogenesis occurring both here in the mitochondria and then in the endoplasmic reticulum. So it regulates multiple enzymes at both these sites, so that there is more generation of more glucose in by the liver by glucocorticoids. And then when you go into these in more detail, when you take this one enzyme, like for example the PepCK gene, there are multiple hormones that can modulate them. So the whole effect of steroids are modulated by other hormones, and these include a variety of response elements that are located on this single gene, the PepCK gene, which is a key enzyme in glucose metabolism. So you have the glucocorticoid response element, you have cyclic AMP response element, you have the retinoic acid response element, and the insulin mediation, the FOXO1 insulin receptor, response element. So these are all multiple effects that are seen by glucose, regulating glucose. And that's one of the reasons why it is difficult to, in the whole body, how the eventual effect of a given dose of steroid is seen, because there are so many other inputs that are there. So that actually will determine whether or not there is an effect of a given dose of steroid or an elevation in steroids that occurs naturally. And then you have effects that are peripheral, but at the level of the liver and in the muscle, which are not direct from the glucocorticoids regulating these enzymes, but their effect on the effect of insulin. So glucocorticoids do modulate insulin action by decreasing the effects of insulin, and you can see at the multiple levels of the insulin signaling pathway that you have a decrease in action of the of insulin by glucocorticoids, both at the muscle and at the level of the liver. So this is a overall view which gives you that, when you take the whole body, then you have multiple organs that work together, and glucocorticoids have impact on appetite. So it increases appetite, stimulation. It causes muscle atrophy. And then, as I said, there's hepatic steatosis, then increase in central adiposity. Then you have beta cell failure and lipotoxicity. And then, of course, osteoporosis, which, we may think it has nothing to do with glucose metabolism, but, there is a lot of evidence now to link the effect of what the osteoclasts can do in terms of how they affect glucose metabolism, both through insulin secretion and also insulin resistance. So you have all of these pathways. So when you look at glucocorticoids, they can affect glucose metabolism at multiple levels. So that is important to recognize, because these could be sites where you can have intervention, and different individuals. And we have heard people, when you give them steroids, they will say that I feel very hungry, or they eat a lot, or people who notice that they have a lot of loss of muscle mass, the weakness that they might see. So there are multiple effects that you see from these glucocorticoids. So there are certain things, as I said, because the whole body is involved in the effects of steroids on glucose metabolism. There are risk factors that play a role in development of hyperglycemia related to glucocorticoids, whether it's endogenous or exogenous. So, of course, type and dosage of the steroids. So it depends on the potency of the steroids and the duration of action of these steroids. Route of administration. So obviously, enteral and parenteral routes are the ones that cause the most effect, whereas inhaled steroids and topical steroids have a much lower effect on glucose metabolism, although they can have, depending on the dose, effect on glucose metabolism also. So we do see some case reports where people have used high doses of inhaled steroids, and they have developed worsening of glycemia. Advanced age is an important thing, so it's more likely to occur in people who are over 60 years of age, and those who are obese or overweight, particularly abdominal obesity, and those with hypertriglyceridemia. and a prior history of impaired glucose tolerance or a high A1C, which is basically telling us about prediabetes. Specific single nucleotide polymorphisms have been linked to higher rates of abnormal glucose and diabetes in patients receiving steroids, those with GFR less than 40, history of hypertension, smoking, and interestingly, CMV infection, race and ethnicity, and concomitant immunosuppressive use. Like, since we see this as quite a common problem in post-transplant diabetes, when you're also using other immunosuppressant agents or even diuretics such as furosemide, they increase the risk of development of hyperglycemia in people who are exposed to higher amounts of steroids. So, not everyone who receives steroids will develop hyperglycemia. In endogenous Cushing's, you have about 50% who may not have hyperglycemia. So about 50% will have either prediabetes or diabetes. So it varies depending upon a number of other factors that may be present. So as I mentioned, they are widely used and can occur through direct signaling, as I mentioned, at multiple levels of the tissues, or indirectly through interorgan metabolite regulation. And we don't have a single consensus as to what exactly causes hyperglycemia in a given patient. So there may be multiple pathways. And then, of course, as in any other diabetes, the mechanisms of fasting hyperglycemia and postprandial hyperglycemia are different, and so we address it differently. And I'll come to the things about how to manage them when I discuss those particular topics. So because the topic is very broad, I did not want to address the full-blown Cushing's syndrome. As we all know that patients with Cushing's, how to manage them. And Cushing's syndrome as such, endogenous Cushing's, is not a common problem. It is about 5, the incidence about 5 per million or so. So it's not as common. However, the use of, the much more commonly seen problem is mild cortisol excess. And there is increasing literature about the role of mild autonomous cortisol secretion and its impact on glucose profile. So this is something that I will discuss so that we can get some idea of what we may or do, although the literature there is not as clear cut as we would like it to be. So this is a review that looked at this meta-analysis of a number of studies, and they started off looking at the literatures, trying to see multiple terms that they used to screen for, and they were finally able to use 37 studies that they looked at addressing the issue of diabetes and hyperglycemia in individuals who have adrenal nodules, both with mild adrenal and autonomous cortisol secretion and non-functioning adrenal incidentallomas. And this is kind of the broad summary of what they had. So the first thing is that most of these are retrospective or cross-sectional. So there's really not much data prospectively for us to say much about these. There were 3 prospective studies, but the majority of the studies are retrospective. Female population was slightly more predisposed to developing hyperglycemia. The female to male ratio was 1.47. There is, however, not so clear cut when you look at the glucose profiles of these individuals. So in this one, in this particular review of all these studies, they found that mild autonomous cortisol secretion prevalence was 10 to 30% of adrenal nodules among what they call non-functioning adrenal incidentalomas. So most of them would tell you that there is a higher prevalence of type 2 diabetes in MACs versus non-functioning adenomas. That means 12% versus as high as 44%. But there are some studies in which they have shown that non-functioning adrenal incidentalomas also have some higher rates. There's one study where they had 45% diabetes. And of course, studies which show that the overall prevalence of type 2 diabetes in individuals with mild autonomous cortisol secretion was higher than that of otherwise healthy individuals. So the question is about the severity and whether those who have Cushing's syndrome have, worse or, better blood sugar readings. And that means the classic Cushing syndrome versus mild autonomous cortisol secretion. So there are not enough studies where we can compare them straight away and say how much these two will be. The follow-up is not that great. The longest period of study was of 10.5 years. And if you look at it over time, you will see that over a period of about 10 years, the increase in type 2 diabetes rate was at 17.9% with a baseline at 0.03%. So over the number of years, you have an increase in the incidence of diabetes. So you also have, they have looked at what will happen if you do adrenalectomy or, what is the best management plan as to what will happen. And I'll come to that a bit later. But you will see that the number of, most of the studies looking at the effect of adrenal surgery have been in patients with adrenal adenomas and Cushing's rather than with mild cortisol excess as to how much of an impact it would have, comparing it to medical treatment or observation. So it is important for us to recognize that there is a higher rate of this. And as I will show you later, the decision on how to treat them is based on multiple other factors. So this is not the only thing that you take. The other area that is of relevance in this is the prevalence of insulin resistance in individuals with an adrenal nodule. So this has been of interest because it has been noted that individuals with adrenal mass have higher levels of insulin resistance. And it is not clear as to whether insulin resistance caused the problem or whether the adrenal, the cortisol excess caused the problem. So there are hypotheses that have looked at whether it is possible that insulin resistance is causing or has some role in the development of adrenal nodules. So one of the hypotheses that has been postulated is that that there is hyperinsulinemia, upregulation of the growth hormone receptor, increase in IGF-1, which in turn leads to an increase in cortisol secretion, and also, which eventually leads to the development of these, especially an increase in IGF-1 as being a factor that increases the risk of developing adrenal nodule. So it's not something that is easy to prove because we do know that.
But just for any incidentoma, not for max.
Correct. This is just for any incident alone, So, I mean, obviously there is a slight increase. There has to be, and these are non-functioning adrenal nodules, but now there is some degree of. So the hypothesis here is that they are secreting, and they are causing some degree of insulin resistance, and that, or there's an underlying insulin resistance, which in turn is causing an increase in IGF-1. Because of upregulation of this receptor, and then that in turn is causing an increase in development of these nodules. So when we look at these adrenal nodules, there are, there's a question of, initially we had non-functioning adrenal nodules and Cushing's, or, endogenous, adenoma causing Cushing's. So now we have this intermediate category, which we call, mild autonomous cortisol secretion. So where do these fit in? And especially when we look at bilateral adrenal nodules, which we seem to see quite often, are they all, in what spectrum? And this is an interesting review that was published quite recently. I think it was in 25 that this year that was published, where they looked at these things. And so one of the things, we are aware of this particular problem, which is, so there are multiple genes that have been linked to development of adrenal nodules. So here what you have is the food-dependent Cushing syndrome, which is the intermittent, which is due to a generation of ectopic GIP receptor. And this is due to a mutation in the KDM1A gene, which will lead to the ectopic expression of the GIP receptor. So when you eat food, GIP goes up, then you secrete more cortisol. So that's the mechanism that is. So this is the particular gene involved there, and then you have ectopic. This is the bilateral macronodular adrenal hypoplasia. Then you have the MC2R mutation, and then you have Cushing syndrome adenomas, and then you have the particular mutations related to pigmented nodular adrenal disease. So there are these multiple disorders with different mutations, including one with the ARMC5 mutation, which is the causative gene for PBMAH. So when you look at this group, so the previous concept was you had these non-functioning adrenal tumors, and then you had these functioning tumors. So some of them were causing only a mild excess of cortisol, and some of them were causing full-blown Cushing's. So when you look at the genetic profile, what you find is that the mutation that is seen here with the non-functioning adrenal adenomas and those with their MACs are similar as opposed to Cushing syndrome. So the hypothesis is that this group are closer to each other than those that cause Cushing syndrome. So that from a genetic perspective, that the MACs are closer to the non-functioning adrenal tumors rather than to those that cause Cushing syndrome. So this is from a recent review that gives us an overall picture of the development of these multiple, abnormalities related to adrenal nodules in with or without Cushing's or excess cortisol secretion. They cause, so these are the different genetic mutations that I talked about. So you have unilateral sporadic adenomas, Then you have the germline mutations, which could be unilateral or bilateral. And then, and these are the common genetic abnormalities that are seen. And then these are the things that can also be secreted by these tumors. So when you look at the overall picture, you will see here that you have, non-functional adrenal adenomas of all the incidentalomas, 40 to 70% are non-functional. Then you have 4 to 12% that progress to max over time. So at any given time, anywhere from 19 to 50% of adrenal incidentalomas have max. So this variation in the percentage of these tumors that have autonomous cortisol secretion, you can see that it's quite broad. And then you have, and the criteria they have used using the 1 milligram dexamethasone suppression test, looking at whether it suppresses to less than 1.8 or it doesn't, so the level is more than 1.8. There are some people who want to change that cutoff to even lower numbers, which will increase the number of patients that people say have max. And then you have, less than 1% of the max actually progress to overt Cushing syndrome. And as I said, about 1 to 4% of adrenal incidentalomas have Cushing's. So, it's difficult to see who will actually progress, but some of the things is females, a younger age group, bilateral tumors, and higher levels of cortisol on the 1 milligram dexamethasone suppression test are more likely to, have worse cardiometabolic outcomes, and maybe the ones that we have to look at to treat. So the general recommendation would be, if you find an adrenal incidentaloma, do a history and physical, do the dexamethasone suppression test, and look at independence, ACTH independence by looking at ACTH level and DHEAS levels. And then you have max diagnosis at which, the considerations that we take into the picture include age and functional status, imaging characteristics, degree of level of cortisol, comorbidities, availability of surgical expertise, and patient preferences. So these are important. In making a decision rather than simply the lab values that we get to decide on whether or not someone needs to have an intervention. So these intervention could be surgical or it could be medical therapy. So just show you some examples of what might happen. So this is a study that looked at what happens with osilodrostat, which is an inhibitor of 11-beta hydroxylase enzyme. And so this study looked at the effect on blood pressure and glycemic control in patients with Cushing's disease. And you can see here that there is a significant decline in the number of individuals who have blood sugars that are more than 126 or diabetic or pre-diabetes, and more people will have blood sugars this is the fasting blood sugars in the normal range. And you will see the same thing with A1C and fasting and postprandial blood sugars. So what they had shown was that, reducing the cortisol levels using this will decrease the hyperglycemia in these individuals. If they are in the diabetes range, they can come down to the prediabetes range, of prediabetes becoming normal. Although, the percentages are not as impressive as you would think, but these all had milder disease. And there were very few patients actually who were MACs in this particular study. So this is the study that looked at, this is the Catalyst study, which looked at individuals who had poorly controlled diabetes and screened them for presence of hypercortisolism by doing a dexamethasone suppression test. And then they were treated with mifepristone, which is a blocker of the glucocorticoid receptor. So, or Corlym, which we have been using in Cushing's. And again, what they did show was that there was this was published recently in June, showing a significant reduction of about 1.22% in the hemoglobin A1C in patients who received mifepristone. So what we can see is that medical treatment can improve glycemic control. When you look at this study here, what you see here is the effect of surgery, and this is the effect of these are non-functional adenomas looking at cumulative cardiovascular risk. These are those who had surgical treatment and those who had medical treatment. So you will find here that when you compare it to individuals with non-functioning adenomas, you will see that medical treatment versus non-treatment adenomas, you will have a much higher rate of cardiovascular risk. And when you look at the cumulative survival, you will see that individuals with non-functional adenomas have a longer, they have better survival than those who have any degree of excess cortisol secretion. So that is the basis for recommending some of these things. So these studies in general, that if you identify hypercortisolism in individuals who are diabetic by doing a poorly controlled diabetes, then and if you also find that there is evidence of hypercortisolism, that you can use these agents to reduce to improve their glycemic control. But you have to be very careful in selecting these patients. So this is something that we have, there's not as much experience in the general population, in the general clinics, as opposed to this particular study. This one here, the Illustrate study, which was also published this year, looked at it from the point of view, looked at using osilotrostat in Cushing's in real world. So these are not a controlled population. But again, the number of people who had Cushing's due to adenoma was quite small compared to classic Cushing's disease. So, but again, they were able to show that in a population with adrenal Cushing's, that you can reduce their cortisol levels and improve overall comorbidities by using medical treatment. Exogenous steroids, of course, are the most common and most well-recognized hypercortisolism that we have. The exact incidence is not known because a lot of people who receive steroids are not tested for their blood sugars, whether by fingerstick blood sugar or any other ways. So in general, it is underestimated. Fasting glucose and insulin level, some people may get some fasting glucose, but most of the time it's a random glucose, and very few people get a glucose tolerance test. But it is fairly common. It is estimated that about 15 to 40% of the overall incidence when you give among patients receiving glucocorticoids will have hyperglycemia or diabetes. And what you also see is that approximately 2% or so of new onset type 2 diabetes are actually glucocorticoid related. So that is throughout the world. So given the high prevalence of diabetes, the glucocorticoids role in causing some of these problems is very important. It's also important to recognize that they seem to have an impact on both short-term and long-term mortality and morbidity, but unfortunately, we don't know for sure. Acute and chronic hyperglycemia, in many cases, we recognize it in the hospital where they get higher doses of steroids. People who are there for a longer period, What we know though is that it does prolong hospital stay. They have developing hyperglycemia. It does increase infection complications and has worse surgical outcomes and increased mortality overall. But what is not known is whether it's the underlying disorder that caused the increase in mortality, because patients who receive steroid tend to be the sicker patients. So that is something that is not fully understood. Also, you have higher rates of diabetes in patients receiving steroids who have malignancies, because this use of steroids as part of many cancer treatments. So that's one of the other areas where it gets more difficult to figure out what is the impact of hyperglycemia on overall mortality, and whether that's hyperglycemia is just a surrogate marker of severity of illness rather than a cause of the worsening outcomes in these. And most of these are observational studies, so we don't have clear-cut data on these things. So, of course, nowadays we're using continuous glucose monitoring systems. So when you look at it, there are a number of studies that have been published looking at different steroids and looking at what is the profile of these. And one of the things that you see here, so this is a study that had 60 patients with COPD, and 7 of them had pre-existing diabetes. And you can see that about 3 hours after is when they begin to have hyperglycemia. Peaks occurs about 5 to 8 hours with 20% higher glucose and wears off overnight. So many of you would have seen this in the hospital, and you're called to see patients with who are started on steroids as to this profile, that the blood sugar, they give it in the morning. Usually by lunchtime, the blood sugar is not that high. It starts going up, and they are highest, at supper time and a bit later, and next morning the blood sugars are doing fine. So this is when you're giving a single dose of steroids. And then you have, different doses and different underlying conditions where you will see different patterns of the development of hyperglycemia. So there are quite a few studies that have looked at these patterns, but you can see that the numbers are not essentially too high in looking at 60 patients, 70 patients, 15 patients. So, and then you can see also that the dosing regimen for steroids is very different in each of these. So, which makes it very difficult to come to some broad conclusions about what, how to diagnose or manage these individuals. And one of the things here, for example, when you're giving 500 milligrams IV daily for 3 days, 5 patients without pre-existing diabetes, this is for thyroid ophthalmopathy. So this is a Graves' disease, and this is the high dose that they gave. And you can see all of them developed, glucocorticoid-induced diabetes. So, they all had much higher, but the dose that they gave here is quite high, and the drug that they used here was interesting because they used repaglinide for this particular population to see and they compared it with metiglanide. And I'm not sure exactly why they chose that combination, which we generally don't. But this is an outpatient population, so that is one of the important things, because if you're getting a patient who has not used insulin in the past and you're going to put them on this high dose steroids and the blood sugar go up, it's easier to tell them to take a pill rather than tell them to start taking a shot. So so when you look at that, there are other things which are kind of interesting. Whereas this particular report, looked at what they called as a triphasic response, and this is with dexamethasone. So, and this is common for patients who are receiving chemotherapy, and they receive repeated cycles of steroids. And what they had noticed here was the increase in blood sugar. This is dexamethasone that they receive for chemo. Here you can see that it goes up, then it actually drops down, and then again it goes back up. So this is at around, this is where they get the medication, then it goes up, and then it dropped about 48 hours later, and then after another 24 hours or so, it went back up again. And one of the things that they had out there was that over time, with repeated doses, they eventually had mild hyperglycemia, mild diabetes, then eventually the A1C went up. So, it is, even though they have increased the doses of the insulin they were giving, they still had worsening of their diabetes. So this is where it is important to recognize as to how aggressive you want to be in the management of these individuals with who develop steroid-induced diabetes in part of their chemotherapy regimen. And then you also have some of these patients who receive higher doses. So this particular study looking at breast cancer patients, and again, you can see here their pattern and baseline euglycemia, only 3.9% of the time was spent in the hyperglycemic range. This one here, baseline pre-diabetes, about 10%. And if you have baseline diabetes, you have majority of the time they are hyperglycemic. So if they have a diagnosis of diabetes prior to receiving steroids for and during chemotherapy, you can expect that they will have persistent hyperglycemia, and some intervention will be needed. So again, the same risk factors that we talked about for development of diabetes in endogenous Cushing's applies here, such as dose and time of steroid administration, age above 60, history of impaired glucose tolerance, history of gestational diabetes, PCOS, family history of diabetes, obesity or overweight, smoking, gender. So there's an increased risk in Black individuals, and there are some HLA types which have higher incidence of steroid-induced diabetes, loop diuretics, and then genetic factors that may play in the development of diabetes in individuals with receiving steroids. So in general, this is the pattern that you will see with the different steroids that are commonly used. If you use hydrocortisone, you get your peak blood glucose at 3 hours, duration, that you will find 8 to 12 hours. That is duration of action of the steroid. And then you have prednisone. The peak is seen at 8 hours. Dexamethasone is variable. And these are the potencies that you have and the anti-inflammatory activity. So most of the, so depending on how frequently you give these medicines, that you will have a pattern of hyperglycemia that need to be addressed. So the recommendation would be, as to when you want to, how to monitor these patients depends on their prior diagnosis, as to how often you want to diagnose, I mean, to recognize it, do blood sugar checks, and then when you will have to and what type of monitoring needs to be done. So when you look at the intervention, as I said, there are multiple sites of effects of steroids. So this is particularly relevant for the outpatient setting if they're going to be on steroids as outpatient, because in the inpatient setting, we almost always rely on insulin. That's what the ADA recommendations are, and we rely on insulin treatment for inpatient hyperglycemia for when they're on steroids. The inpatient doses are also higher than what you give as in the outpatient setting, and you can see that different drugs like the address the effects of glucocorticoids on at different sites, like increased appetite, to GLP-1 analogs and DPP-4 inhibitors, impairment of increase. So you can use and then you have lowering of renal threshold for glucose, and now you can use SGLT2 inhibitors, insulin metformin for its effects on increased lipolysis, the thiazolidinediones, which you don't often use, but a lot of European studies do use both metformin and TZDs to reduce, the increase insulin sensitivity. And then, of course, for beta cell function, you can use sulfonylureas, glanides, and also insulin itself. So when we look at this here, you can see these different agents that are there. And on this side, you have here is what it affects, that it has on these studies looking at the effect on particularly in glucocorticoid-induced diabetes. So sulfonylureas improving fasting glucose, especially when you're using the longer-acting sulfonylureas. They act quickly. That's one of the advantages there. And for postprandial, they have used, glanides, incretin-based therapies. Not a whole lot of studies, but theoretically, it can be, it does improve mean and postprandial blood glucose levels. Then you have DPP-4 inhibitors, metformin, TZD. So a whole range of these drugs can be used in the outpatient setting, depending on the severity of hyperglycemia and the type and the dose of steroids that you're going to use. So in the hospitalized setting, this is a schema that we have. So you have, if the glucose values are less than 140, you just do regular blood sugar checks. For those who are 140 to 200, non-critically ill, you can consider oral agents. If they are critically ill, insulin and either subcutaneous or IV insulin drip. Then you have, if the glucose values are over 200, then you use insulin as the primary agent. And depending upon the glycemic profile, if it is postprandial, you can see here occurring early, you're using high peak, fast-acting insulin. Then here, if you have longer duration of hyperglycemia, and then you can use either intermediate-acting insulin or long-acting insulins, which is NPH or glargine or detamers. So you can see here the therapy initiation using different doses. For rapid-acting insulin, it's 0.1 unit per kilogram per, and this is if it is given twice daily, you use 2 doses. If it is for the NPH, we're using anywhere from 0.2 to 0.4 units per kilogram body weight, and you adjust it depending upon blood sugar and also on the GFR. And this is for NPH, so you can use the different profiles. And then therapy adjustments based on the blood sugar readings at different times. And intensification based on the response that you get. So this is just something that you can, it's a simple card that you can carry that helps you keep track of what the blood sugars are going to be. And this is a strategy for what you need to do once they're admitted. You've started glucocorticoid and you've followed that protocol. And depending on at the time of discharge as to what the patient needs, whether they need to continue to be on some sort of treatment, and this is particularly relevant patients who have not been diabetic before they were admitted, and those who are diabetic and in whom the treatment regimen has been changed. So by the time they are discharged, you'll have to educate the patient about the nature of the steroid-induced hyperglycemia and the medications that you're using, blood sugar monitoring, use of insulin if needed, and then give them targets of what is expected, and then how to contact the hospital or outpatient staff and make a follow-up appointment, and then follow up about the use of subsequent monitoring with hemoglobin A1C, and then of course, kind of transitioning to their usual care. So this is an outline of what GLP-1s could be helping in terms of for steroid-induced hyperglycemia. As you can see here, they have multiple effects. So in general, they will have significant benefits. The main problem with the use of steroids, with the use of GLP-1 analogs, is their impact on appetite, and whether patients who are very sick, they are able to eat, and if they're also on other hypoglycemic agents, whether that will lead them to develop hypoglycemic episodes. So those are things that we have to keep in mind. So better make that decision. Perhaps we don't generally start too many patients on GLP-1 in the hospital, but this is a good opportunity to discuss this choice of medication when they are in the hospital. And this is just another version of the same thing that I showed you before, looking at the impact of different agents on fasting blood glucose, postprandial glucose, A1C reduction, weight, and the disadvantages, cardiovascular risk, risk of fracture. And whether they are suitable for the type of glucocorticoid-induced hypoglycemia. So depending on which type of medication, insulin secretagogues or insulin itself, and other agents as to which ones are most effective. So in addition to that, there are some other areas where people have tried to develop agents that may be very specific to glucocorticoid actions that lead to hyperglycemia. So as I said, the mechanism by which glucocorticoids cause hyperglycemia is partly directly in the liver and in the adipose tissue. So there are agents being developed that target the gluconeogenesis in the liver and lipolysis in the adipose tissue. These are all in very early trials, phase 1, or even in animal models. None of these are yet in the clinical field in terms of available for clinical practice. And these agents are, would in the future hopefully be useful in kind of targeting treatments where you can dissociate the gluconeogenesis effects from the anti-inflammatory effects. So we have not been very successful in developing those types of agents. And then you have the 11 beta HSD1 inhibitors. As you know, that is a key regulator of active versus inactive steroid and its effect on different tissues. Again, this is still in early stages of development as such. In terms of monitoring, this study looked at different things as to whether, comparing continuous glucose monitoring versus using A1C or fructosamine or 1,5-anhydroglucitol. And they were all very similar in terms of they are comparable. So you can use one or the other depending upon the time frame that you want to know. A1C, of course, we're looking at a 3-month period. With fructosamine, we're looking at a 3-week period, and with 1,5-anhydroglucitol, it reflects postprandial hyperglycemia more than it reflects overall hyperglycemia. However, when you look at it, you will find that all of them are very similar in terms of being able to give us an idea of how good the glycemic control is. So all of these can be used. So if there are reasons to not use one or the other, you can choose one of these alternatives. So this one here, as I said, is slightly different from the ADA recommendations in terms of simply that it adds other options of management, which include using oral agents, using SGLT2 inhibitors or GLP analogs for the management of steroid-induced hyperglycemia. The one thing, though, is that with these agents, they're not, if you go with the guidelines either from ADA or the European societies, they do not add these in their guidelines yet. So they, and mainly because there are no trials that have been done to look at what happens to these individuals. So they give that more as kind of a small write-up about the options. So for both hyperglycemia and for diabetes. So I will end my talk here and will be glad to take some questions. Yes, any questions?
When you showed the algorithm for the different meds, the metformin and the GLP, I know the outpatient, it's always tricky, especially, the glenites is a good idea, but what is the time of onset? Like when we give somebody metformin with a new onset diabetes, it doesn't improve it the same day. It takes a little bit of time as opposed to giving insulin, or perhaps GLP-1 to curb their appetite. That may work, but even that the weekly GLP-1 may not work right away. So in those cases, maybe the glenites or the insulin is what seems like.
Yeah, I think for all of the agents, in general, the ones that act quickly are acting through insulin, either insulin itself or sulfonylurea or glenites. So they also reduce the blood sugar a lot more in the short term, but they also increase risk of hypoglycemia. So that's where the balance is as to what one has to do. Because, when the blood sugars are very high, and that's why this thing is when your numbers are all running over 200, at that point, it's best to use insulin, So when it is mild, so when you're looking at steroid-induced diabetes or steroid-induced hyperglycemia in patients who are post-transplant or being given steroids for rheumatoid arthritis or COPD, and there we have a lot more time. And depending on how high the blood sugars are, we can make a choice of what we want to use. Whereas in the acute situation, there is always this thing that you're trading. And since there is no good evidence in the short term of keeping the blood sugars too tight, that is going to benefit. So keeping, 140 to 200 would be a reasonable approach. You know, as long as they don't go into severe, no. So one thing that I didn't address was type 1 diabetes and pumps. That is a separate thing altogether on how you manage those. So, yeah, yeah.